So, good evening, friends and colleagues and fellow students. The Hong Kong U Ophthalmology Distinguished Lectures features speakers of eminence within and outside the field of medicine and ophthalmology. The first lecture was delivered by Professor Watson Lee from Hong Kong Sanatorium and Hospital. He shared with us about the development of ophthalmology in Hong Kong. The second lecture was delivered by Professor Tony Mok from the Clinical Oncology Department at the Chinese University of Hong Kong. And in that lecture, he taught us how to run clinical trials. The third lecture is an education lecture given by Dr. Andy Chiang from Hong Kong Sanatorium and Hospital, and he shared with us how to diagnose and manage patients with optic neuritis. Tonight, we have the fourth lecture, which will be delivered by our guest of honor, Mr. Derek Hodkey, who is the president and CEO of Orbis International. Before joining Orbis in 2020, Derek was the Senior Vice President and Chief Operating Officer at the Counterpart International, which is a global development organization devising innovative and enduring solutions to social, economic, and environmental challenges. And before joining Counterpart International in 2014, Derek was the vice president at the International AIDS Vaccine Initiative. So Derek has extensive experience in international development and in the sectors of life sciences, biotech, and pharmaceutical sectors. And tonight, Derek is going to tell us the story of Orbis, the Orbis model in global sight saving, the power of innovation. Derek, please.
Thank you, Chris. Thank you, ladies and gentlemen, for this warm welcome. I am delighted to be here with you this evening to talk a bit about Orbis. I am not an ophthalmologist, just so we're clear, but I absolutely appreciate and value all the contributions that you are making and will make to this field. And I hope through my talk tonight, you will learn more about why the career path you've chosen is so vitally needed and so important. I am a medicinal chemist, so I am a bit of a science geek. I started my life trying to find the next cyclosporin drug, working in pharmaceuticals and, as Chris said, in biotech. So I've spent about 15, 16 years in the for-profit sector, 15, 16 years in the nonprofit sector. And so in that regard, I've tried to bring what I think are the best attributes of both experiences into my role as CEO. Honestly, I never had being CEO as an aspiration. It wasn't something in my life plan. But what happened was I was approached by a headhunter who said, there's an organization called Orbis International that is looking for a new leader. Would you consider this? And the more I looked at what Orbis does and how it does it, I became intrigued. Because the Orbis model is about sustainability. And that is one of the biggest challenges facing international development, is the deployment of sustainable solutions. And so as I talk with you this evening and share both the Orbis model and some of my most recent experiences visiting our country offices, I hope you'll come away with an understanding of why that sustainability is so important, why it's so key to Orbis's success, and hopefully you'll become excited about the sustainability approach as well. And maybe you too, like Tim Lai here, will want to be a volunteer with us at some point. So I have lots of slides. I am not going to read slides to you. You're all very smart, and I know you don't want to have slides read to you. There will be a few that I will focus on because I want to emphasize something. But certainly these are the topics I'd like to cover tonight and really go through with you the vision of change and the items that I have listed here. So this is one of those I'm going to read a little bit. You know, for Orbis, what we believe is that what we need to do is make long-standing difference to strengthen health systems. That our 2022 to 2026 global strategy, which we launched just recently, really focuses on the need for equitable access to eye care. And you'll understand more when I talk about some of my most recent experiences. And of course, for us, very key to this is ensuring that no one goes blind tomorrow from avoidable causes. And this is really what I think a lot about when I think about our work, when I talk to donors, when I talk to partners, and hopefully you'll see some of these themes as I go through. So with respect to quality and accessible care, some of these things you already know. 1 billion people living with some type of vision loss. Over 300 million of them have some form of either blindness or moderate to severe vision impairment. But the most important thing is the vast majority of these cases are preventable. And the challenge is access to care, good care, quality care. And where do these people live? In low and middle income countries. And if you look here, you'll see over 60 million people are going to be estimated to be impacted by blindness by 2050. So there's an imperative, there's a sense of urgency in what needs to be done. For those of you that track things well with the UN, you'll know that there are those Sustainable Development Goals, 17 of them. And if you look at those 17 goals, you can draw a line to 10 of those that relate in some way to vision, whether it's alleviation from poverty, whether it is the opportunity for good education, whether it is being able to move off of social services. There are so many different ways that vision touches what the UN is driving countries to really focus on in order to improve the quality of life for people around the world. So when I came into Orbis in September of 2020 during the pandemic, I inherited their last 3-year strategy, which ended in 2021. And my team knows that I'm pretty plain spoken in terms of my opinion, and so I'm going to be plain spoken with this friendly audience and say that what I inherited was not a strategy. It was a task list, and it was not inspiring. So for me, as I thought about this journey of being a new CEO, I focused on 3 elements. The first is, what drives Orbis? Why do we exist? And as I talked to colleagues and we met and we discussed this, it was like, well, to prevent blindness. Yeah, but how? By doing programs. So I really focused the organization to think about that we are a program-driven organization. That was the first part. The second part comes a lot from my experience in the corporate world. We need to make sure that we align ourselves to be fit for purpose. And my team knows that they've heard me say this a lot too in meetings. So really looking at what do we need in order to achieve what we want to be. And if there are things that we don't need anymore, get rid of them. Align ourselves to be fit for purpose. And then the third part, from my years in working in international development, and those of you in this room who are looking to make big change in the world through your career choices, is what's important to donors, what's important to people. It's not how many trainings you do, it's not how many procedures you do, it's the impact of what you do. And so for me, it was, we have to be a program-driven organization, and we have to be fit for purpose, and we have to be focused on delivering impacts. I was asked, what is my revenue target for Orbis? I said, I don't think that way. I don't think that way. My objective is to be the most impactful organization we can be. And when I was a young chemist working at Merck Sharp and Dohme, I would walk through the lobby of our headquarters, and there was a portrait of our founder's son. And underneath his portrait, he said, If we make the right medicines, the profits will follow. And I believe the same is if we're doing the right work, demonstrating the right impacts, people are going to want to work with us. People are going to want to be in part of that change. And so that's what inspired me as we move forward on our new global strategy. So when you look at this, we started with some core principles. We started with some 5 key elements. These program priorities became the nucleus of how we thought about our new strategy. Pediatric eye care, trachoma elimination, primary eye care, building eye health capacity. And then one that was particularly important to me from my experiences in international development and working in countries like Afghanistan and others, equity. Making sure that women, young girls, persons with disabilities and displaced persons have access to care. From that, we then thought about how do we move this forward? And we came up with these 5 strategic pillars of program delivery, people, systems efficiencies, revenue, and thought leadership. That became the core of how we are going to move our strategy forward. And then we had our 4 cross-cutting themes. How do we get that work done? Through partnership, through equity, through technology, and as a learning organization. This is what moves us forward now, and this is how we are going to become an impactful organization by the end of 2026. So we're going to really try hard to get there in that time period. Because strategies need to be a vector in time. They need to be directional. They're not going to be absolutely 100% specific, but they're going to say, where do you want to go? So with respect to, there we go. With respect to program delivery, you can see what we decided here is we want to be an ophthalmic leader in services delivery. We want to make sure that we're talking about sustainable program impact and the things that we have listed here. With people, one of the things my team will recall when I came on board, I said we have to put our people first. We have to be able to take care of our staff. We need to be able to take care of the people that count on us. So that became a core priority, and some of you will recognize some of the faces in this photo as well. Revenue. Hey, I'm a CEO. We got to raise money, right? So we got to be able to do what we need to do to have that impact and change. But we want to make sure that we're looking at partners who mirror our values. Partners who are also looking at how we can engage with our donor base as well as with institutions that are like-minded. Thought leadership. I think I've been invited here today because many of you recognize that Orbis is a thought leader in terms of what we are doing, and many of you are part of that. You've contributed to that either through your own efforts as volunteer faculty, through participation in research with Orbis, or because you've also seen some of the innovations that we've made at Orbis that are helping to transform learning in the ophthalmic space. And efficiencies. I'm a Myers-Briggs ESTJ. I'm a data-driven efficiency kind of guy, right? So we need to make sure we're being smart with our dollars because every dollar is earned and donors want to make sure that they're getting the value out of that. So we need to look at how we can be efficient. We need to be transparent. And as my team also knows, when I came on board, I talked about a model of the 3 T's, trust, transparency, and timely communication. That's how we need to be able to build trust. That's how we need to be able to work with donors. That's how we need to be able to treat and work with each other. So with these 5, we then talked about our cross-cutting themes in terms of partnership, learning, technology, and equity. And again, as we look at engaging with new partners, looking at them with this same lens. So when we look at our programs, our global programs that we have, for those of you who aren't that familiar with Orbis, we have 7 country program offices, 2 in Africa, 5 in Asia. But we also do some program work in other countries in Africa, as you'll see there, Ghana, Rwanda, and South Africa. And then we have an active project in Nepal. You can also see here, all 54 countries in Africa are on CyberSite. All countries in Asia, except North Korea, are on CyberSite. It's become one of our biggest assets. It is what saved our butts during the pandemic, if I could be so bold. because it allowed us to continue our mission of training and building capacity of skills so that we didn't lose a beat. And it is something that I'll talk a little bit more about as well. I'm sure that some of you have probably explored CyberSight on your own. I'll also do a pitch right now. You can get it on your mobile phone through Apple or Google Store. You can download it and also look at CyberSight there as well. One of the things that we weren't doing very well when I first came on in 2020 is Orbis was very siloed. Our country programs were kind of working independently. Our technology team under Dr. Hunter Cherwick, who's our Vice President of Clinical Services and Technologies, was creating a lot of good assets, but they weren't being pulled into the countries. We've changed that. So with our new head of global programs, Doris Macharia, who's based in South Africa, with Hunter, and with our director of the Flying Eye Hospital, Morris Geary, we're now more integrated than ever before in terms of the tools that were developed in order to make sure that we're getting the biggest value, coming back to that efficiency aspect again. It was also incredibly important as we think about how we look at strategic development and expansion going forward. And for this, as we think about how we can improve our program interventions, again, to be more impactful, we want to make sure we're using all the assets that Orbis has invested in. You're all familiar, or many of you are familiar with the Flying Eye Hospital, which has been around for 41 years. Orbis has been around for 50 years. I've been around for more than 50 years. And CyberSight celebrates its 20th anniversary this year. So there are lots of things that the organization has invested and done, a lot of growth that we've taken advantage of, or that we've had, excuse me, now it's time to take advantage of it and leverage it across our programs. So for our country programs, our head of programs, Doris Macharia, started with a theory of change, which many of us love these things. It helps us stay grounded and think about where we want to go. And so for the different types of interventions, service delivery, as you see listed here, not only did they talk about outcomes, they started to think about impact. So one of my colleagues from our monitoring, evaluation, and learning team is here today, and she and I were just chatting before this, and we went through a big reorganization within our monitoring and evaluation efforts recently. So many of you know collecting data is important to help tell the story. We had 1,700 indicators at Orbis. You know what you get out of 1,700 indicators that is useful? Not much. Not much. So the team has now gone through, and we now have 99 output and outcome indicators, which are going to allow us to have the scaling impact or the multiplying impact of looking across programs because we now have standards. And then as we rolled this out at the beginning of this year in the first quarter, these new 99 indicators, the task for the team next year is going to be mapping those indicators to impacts so that we can talk more impactfully about our story, so we can look at the cost benefit of what we're doing, being able to really tell, yes, we've been able to do X, Y, and Z. My team also knows I have this aspirational goal of longitudinal patient follow-up. I keep talking about it and talking about it. We're not there yet. I haven't given up on it. I think we can still do it, but it's you have to walk before you can run on some of these things. But certainly with respect to our programs and in terms of how we're looking it forward, you can see, again, as I said earlier on, I'm a data geek, so I love looking at data. I also believe in the power of research. But what we were doing was we were doing some really good research, but it was not cycling back into program design. So we've changed that now. So all of our research efforts have to inform the next generation of programs so that we can then continue to look at that where the value creation is and make sure that we're being smart with how we're investing our research dollars. But as you'll see here, while we look at a number of the things that we have to continue to do, and I'll talk a little bit more about this, integration of eye health systems and ophthalmic and services is something that it's still a need within many parts of the world where we work. AI is really helping out a lot. The challenge is that I think many people know, people are confused about what AI means. They think of ChatGPT, they don't understand what the difference is between what medical applications are, and I get asked this question a lot, as I'm sure many of you do as well. But the power of AI is really going to help us because we look at it as machine mentoring, really helping ophthalmologists and other medical professionals in the eye health space become stronger and smarter in learning to be able to treat patients and develop their skill sets. We also continue to need to build more capacity in ophthalmic services. I'll talk about this with some of my observations near the end. Pediatrics, I'm not going to lie, is a passion for me. I love kids. I believe that kids have to have the best start in life. We need to do everything we can to try and help them. And there is so much demand for pediatric services that I've seen recently from my 3-country visits that it's something that I hope many of you also think about as you think about the trajectory of your own careers, whether pediatrics becomes a big part of that or not. Referral networks, policies, I can go on and on about the need for advocacy. Advocacy is like research. It's a black box. You can put lots of money into it and not be clear what you're going to get out of it. So it does require some concerted efforts. It does require trust building with governments. It does require KOLs to be on your side. It requires many different things, but it can have positive benefits. We have now a situation where in Vietnam we are getting that physicians are being reimbursed for DR screening with AI, which wasn't happening before because we were able to make the case with data to talk about the important benefits of it and the economic benefits. Governments understand economics. You can make the economic argument first, then you can make the quality of life argument that helps follow. You start with the quality of life, they'll say that's nice, but how's it going to help save my budget? Right? Human resources for eye health. I don't know how to not stress this more. We need more of it. We do. And, in certain countries, there is an opportunity to task shift where you can have nurses take on bigger roles in certain procedures, which don't require the ophthalmologist to be there, therefore freeing up that expertise for other higher needed services. But in some countries, this is limiting based upon the structure. But I will tell you that there is a tremendous demand for human eye health resources. And that's why we at Orbis not only spend so much time and effort in developing our training tools, it's also one of the reasons they're all free. Everything that we put out on CyberSight is free. We believe in the democratization of knowledge. Knowledge is going to help solve this problem in the long run, as long as we have folks like you all in this room engaging. Comprehensive eye care is something that it's hard to also put a value on that because I've seen as well where it is very easy to take it for granted in industrialized nations and industrialized territories where we all live. But when you get out into the more difficult areas and you find that people don't have access to care, you find that they have substandard care. You also find situations where they just don't know what they don't know. You really understand that comprehensive eye care is so important in communities that are limited by their access to it. So part of what we need to do is eliminate barriers, and that's why tools like CyberSight and CyberSight Consult and all of these other features that we've built are important. They help. They don't solve it, but they become part of the solution. And also public awareness. I think public awareness is something that's really important, that we were successful in Ethiopia, for example, where there were healthcare workers that were going door to door to talking about the need to go to the doctor for your annual physical as it relates to certain types of cancer and things like that, but vision wasn't part of it. So we lobbied with the government and we talked about vision should be part of this, and so now it is. So you don't have to have two people knocking on your door saying go to the eye doctor and go make sure that you've had your GI tract tested and things of that sort. It is now all part of one thing, because vision, health, and eyeglasses are not a luxury. And in Ethiopia, for example, when you buy a pair of glasses, you're taxed on the frames. Then you're taxed on the lenses. So there's a double taxation to buy glasses because in many cases, they feel it's a luxury item. But it's not. It's the same thing as when I go get my Crestor refilled at the drugstore for my lipids. It's something I need. Glasses are the same thing. So this basically gets again to the point of, looking for a lot of interventions. School screening programs are key. They've been very helpful. I've had the chance to witness some of those and to talk to some of the children that have been involved in that, and I'll share a bit about that in a moment. And of course, really looking at how we can strengthen the systems through the delivery of tools and technology. Orbis, there's been some questions about, is Orbis going to go into more countries? We had some people say, well, are you going to go into Indonesia? Are you going to go into Malaysia? Hopefully, sometime. But I also want to make sure that we are leaving countries that we're working in now in a good position. I don't believe in going broad but not deep. We want to make sure we understand what's needed in the country before we move too far out, because we don't want to set an expectation that's not going to be met. It doesn't help the community. It doesn't help the healthcare system. And quite frankly, as long as I'm CEO, I'm not going to support it. I want to make sure that we are doing all that we can in the communities, that we are also looking at key partnerships like with COESCA. I think most of you probably know what COESCA is. It's the College of Ophthalmology of East, Southern, and Central Africa. Institutions like that are ones that we want to make sure we continue to partner with. Technology. All right, so we can geek out here a little bit. So as you all know, during the pandemic, everything stopped. But even though we were able to move forward with our CyberSight platform, we also looked at how do we keep our flying eye hospital team engaged. And so we created the virtual flying eye hospital program, which allowed us to continue to train people using the technology that we've created and using the expertise of our flying eye hospital team in order to keep developing skills. One of our VF, John Ferris, you'll notice here, talks a lot about simulation. I know many of you in medical school, since I worked with a lot of doctors in the pharmaceutical industry, see one, do one, teach one was the old mantra. I firmly believe see one, do as many as you can before you ever touch a patient is the way to go. And simulation gives you that. In Orbis, because of our unique blend of aviation history and medical history, learn the power of simulation largely through the aviation industry. And we continue to use this as part of our core curriculum whenever we do a new program. Simulation gives everybody the best chance to learn and develop their skills. And of course, we use the Flying Eye Hospital as a sim center just because we have the capability. But of course, you could set up simulation in a conference room. It doesn't have to be on an airplane. I do love this quote, which this person here, who is a first-year resident from Chile, what I felt is that training increases a lot of your confidence and helps you to face the surgical procedure. I can say that I started this training with 10% confidence and I'm leaving with 90%. Think about that. That means that this person, their personal skills, their personal confidence has gone up because they've had access to tools that allow them to become more confident in their skills, to learn and to engage with professionals who can help them. So for our Flying Eye Hospital program, we've really moved to a multi-year model where in year one, we do a lot of virtual training on CyberSight with live lectures and course content. In year two, as we prepare, because we usually plan these 2 to 3 years out in advance, we do a lot with remote wet lab and simulation training. And then blended learning has become core at Orbis. Blended learning meaning machine learning as well as in-person mentoring. Because again, we want to make sure that everybody who's coming on and having an opportunity to engage with Orbis is learning from as many tools as possible that's going to give them the confidence and the skill sets that they need. So this year we have 2 programs with the Flying Eye Hospital, the one we just completed in Vietnam and the one we have coming up in Zambia. And again, you'll see it's a combination of simulation and surgical. And certainly for Vietnam, the participants are really being trained on glaucoma, not with ROTA, but we're being trained with glaucoma in terms of remote simulation. And what this does is it gives, I see we have the little hand back here again. It basically makes sure that we have an opportunity to continue to engage with our programs, because what we want to do is have this cycle of building the strength through the FAH program. So in Vietnam, we were there for 3 weeks. We partnered with these local hospitals, because when we do programs for Orbis, it's never about volume. Many times I guess, how many surgeries did you do on the plane? 3, maybe 4, because it's about teaching. And it's not unusual for, if somebody comes in, let's say with bilateral cataracts or bilateral strabismus, for the surgeon to do one while the resident watches, and then the resident to do the other one, to learn. And so what we do is, in the structure that we've created now, is we have consultation, which begins well in advance. We make sure that we have the pre-learning built, and then we have simulation, surgical, and surgical. And this process, and Tim Lai can talk about this later over dinner or after the meeting, since he was with us in Vietnam. So again, thank you, Tim. You know, this, and I saw Tim actually leading a lecture on the plane as well during a procedure. This process, we believe, reinforces and strengthens the learning model, because it gives you multiple touch points in terms of simulation and direct mentoring with a professional. So as you can see here, in this case, you know, we talked about for our pre-learning, for our pre-project activities, for the ophthalmology, the nursing, the anesthesiology, because those are the core groups we look at in terms of skill set. Biomedical engineering is so important, because when you get into Outer Mongolia and you have a piece of equipment break, you can't call Alcon and ask them to come out and fix it. You need to make sure that you have people in your team that know how to repair the equipment so that it doesn't sit there because something has broken and won't be able to be used. Nurses, I have such tremendous respect for nurses, because they are so pivotal to what we can do, and the ability for them to support other parts of the value chain, which I'll talk about in a little bit. And of course, anesthesiology is one of those areas as well. So as you can see here, and these slides will be available with Chris, and he can circulate them to anybody who wants to look at them more closely later. But what you'll see is, you know, we have a pretty full curriculum in terms of making sure that the learning experience is maximized as much as possible. And then you'll see in week 2, week 3, again, we have a whole set of procedures that we make sure everything's followed. I've also been asked questions, well, what do you do about COVID? So everybody is tested every day before they go on the plane. Anybody tests positive, you're not there. We had no COVID incidents with this FEH visit. We had one minor needle stick, which was a clean needle. So we did our incident reporting, but we had no issues at all. And what we do is we have COVID protocols, and just like any hospital, we have a strict set of protocols, a strict set of reporting requirements. But here, what this really does, I hope, show you is that we have a pretty thorough curriculum of how we are making sure we get the most out of every opportunity. I'm not going to go through this in detail. It's not that unsimilar to what you just saw for the Vietnam program in terms of what we're doing in Zambia. Again, thinking about the courses for the different participants, the type of programming that we're going to have at the end of September of this year, and so forth. Cybersight. So consult, learning, live teaching, AI. Some of you know this guy right here, my colleague, Hunter Cherwick. I cannot stress enough what Cybersight has been able to do, not only in terms of continuing the learning experience, but also with the tools that we continue to build with it. The AI piece, the machine mentoring, is strong for us. I think in some cases, when you hear about AI, you know, some organizations say, yes, we've got AI, we've got good data, but they have, you know, data from blonde-haired, blue-eyed individuals from, you know, Norway. We have one of the most diverse data sets in terms of looking at, you know, African eyes, Asian eyes, Caucasian eyes, to make sure that we have that type of data in order to increase the learning experience. So I was being kind to my team. They knew I was going to be speaking here, but I did not ask them for updated slides because they were all so busy. So I will update this a little bit verbally. So right now, Orbis has over 80,000 registered users of Cybersight. Before the pandemic, we had 12,000. We're now at 80. We're in over 200 countries and territories. We also have increases depending on time period in consult, library videos, and enrollments. We continue to see good growth in parts of, for example, in this case, in China, in terms of enrollments with respect to our glaucoma. And you can also see here that in the month of September alone, 900 new users are registered in China. We also have a program with Santen Pharmaceuticals in Japan, which is in support of really looking at increasing awareness of glaucoma. So Santen has been helping us with in 3 countries, in Vietnam, India, and China, as part of this. But certainly, this type of growth doesn't happen just because we have a partnership. It's because people start to learn about what we're able to do and find value in it. With respect to nursing, as you can see, and again, I won't read the list, but we've added so many things with respect to nursing. And I'm also pleased to say that we are doing more in translation than we've ever done before. Mongolian and Vietnamese are some of the most popular languages right now on CyberSite. We continue to find ways, but continue to add more translation than we've ever had before. In April, I was in Japan doing a goodwill tour, trying to get Topcon and Zeiss and all these other guys to give me things, including money. Got some interest. I was still waiting to see. But their question was, well, you don't see much in Japanese. And we're like, we know, because we need more of the Japanese Ophthalmic Society to come and be engaged with us. We did have one of our VF there, and he's helping to create more awareness as well. But we are doing as much as we can to quickly put things into new languages so people have more access. We also have our IQ series for those of you who are studying for exams and so forth. There's a lot of good information here to make sure that you can look at, what are some of the typical questions that you might be asked during your residency. And it becomes a strong learning tool. And again, this is all free. None of this should cost anything. It's just you signing up and creating a CyberSite account. We've also have, as many of you know, a number of webinars. We have very distinguished people. Dr. Malik Cahook, many of you will recognize that name from the Cahook Blade. Malik is also the chair of the Orbis Medical Advisory Committee. He was recently appointed to the Orbis Board of Directors. He continues to be an active participant in CyberSite and CyberSite lectures. I think that you'll also see Chris's name down here as well. So we continue to have high engagement from subject matter experts and really leaders in their field. AI. So our AI tool is something that we have really built in-house. We have had conversations with organizations like Google. We've had conversations with others. But we were able to do this, and we have been doing it really well. We did recently a study called the Raider study in Rwanda, where we looked at the importance of AI in diabetic retinopathy screening. Our algorithms are strong. We continue to see AI as not the solution, but part of machine mentoring. I personally never want to take the human out of the element. We should not just put somebody in front of an AI and say, what does this, what's the situation here? We always need that human interpretation, because we also need to be able to train ourselves as humans to know what to look for. In Vietnam, I talked a little bit about this already with respect to, some of the things we've been able to do with diabetic retinopathy, and also with AI in Vietnam. We continue to pursue as much as we can. We also have integrated electronic medical records. All of our medical records for all of our patients that go through the Flying Eye Hospital are kept on there. Our EMR is very strong. We make sure we follow all data requirements. And we continue to publish. So we've had record years, the last 2 years, the number of publications we put out, in terms of making sure that we're informing the global community about what we're doing with respect not only to AI, but also, what we're doing in other areas as well. So in this case, it's AI for DR. Here it was AI for glaucoma. And we continue to make sure that we are sharing with the broader community what we do and inviting them to be part of this with us. Fundamental VR. So this is a company that's based in London. It is virtual reality. And we conducted phase 1 study with them on small incision cataract surgery. And we learned a lot during that. And we are now in phase 2 development with this organization, because while VR, people think, well, haptic game technology, Oculus headsets, how can anybody afford this? Well, we are looking for smart, cost-effective ways to do this. So we could do this for under $10,000. And so what we did is we had our GLOVES study, since all of us love acronyms for papers and so forth. The Global Learning Orbis Virtual Platform Evaluation Study. We had 9 partners involved, as you'll see listed here. And our aim was to really investigate the efficacy of intense VR simulation. And we had a number of criteria, just as you do for any clinical trial. And then we learned some things through this. We learned that we were a little ambitious in terms of what we thought people would be able to do. We also learned that we had to be a little smarter with respect to handpiece design, thinking about, this is only designed for right-handed people. There are left-handed people in the world, and some of these other aspects. So this has helped feed into our partnership with Fundamental VR, which is also called Fundamental Surgery. They are well known. They've done a number of series of fundraising efforts, and this is something that we continue to pursue, and we're hoping to have something to present at AAO later this year. VF, volunteer faculty. We have over 400 volunteers in specializations from anesthesiology to pediatrics to oculoplastics, everything that you can think of, who basically say, I want to help. Whether it's doing an Orbis lecture, whether it's coming out on a flying eye hospital visit, whether it's going to one of our partner countries and doing a hospital-based training, these individuals give freely of their time in order to share their expertise and their knowledge to be able to grow capacity, to be able to treat people who would otherwise not have access to their skill set. So as you'll see here, the ophthalmology community in Hong Kong has been a very important part of our VF history. And, we're delighted that not only have we had, it was our first VF joined us in 2000, but as you look here in 21 and 22, even though the pandemic restricted movement, we continued to have active engagement from the Hong Kong community, for which I'm very grateful. With respect to clinical training, in 2022, we recruited 32 VF, and we had 53 VF as cyber-site users. And while I said, counting things doesn't always help, I'm going to count a little bit here. So with hospital-based trainings, in-person trainings, we trained 532 people. And then when we moved to the virtual platform, we trained another 800. So think about that. That's 1,300 people that have now had access to training from leaders in their fields about things that are hoping to develop their skill sets further in order to be able to treat more patients in their respective communities. So in summary, on the clinical side, for where we are, the Flying Eye Hospital projects and HPTs are more clinically structured and clinically focused than they ever have been before, which I'm particularly proud of. Also, our blended learning model is something that we continue to pursue, both for country programs as well as for our HPTs and Flying Eye Hospital programs. And we continue to look at developing new models for regional and national VF, cyber-site surgical case reviews, as well as, of course, building long-term synergies with partners. Now, as I get ready to wrap up, I do want to take a few moments to talk to you about some of my recent visits. In March, I was in India. It was my first country visit as an Orbis CEO. India, we have been there for 23 years. And the India program does focus on comprehensive eye care, but a large focus has been on pediatrics. And you may have seen some publications about the REACH program, the refractive error among children. This is a program that has treated millions of children in India. And it has done this both through door-to-door programs, which we started during the pandemic, as well as in-person in schools. I had the opportunity to visit 3 partner hospitals, one at Aravind and Madurai. Those of you who know Aravind will know it's a machine. It is unparalleled in terms of what it's able to do. It started as an 11-bed hospital. It's now a network of over 7 hospitals in southern India. We had a chance to meet with the partners at HV Desai in Pune. And of course, many of you probably have heard of Dr. Shroff's Charity Eye Hospital in New Delhi. I will tell you, and it's hard to put this into words, but when I first went to any one of these 3 hospitals, when I was walking into the entrance, I was walking through a sea of people. Buses were bringing people from 200-300 kilometers away to the hospital. No appointments, walk-ins. All of them were for eye care. I've never seen the like of it. In the United States, I'd walk into a hospital emergency room and I would see broken arms or, some type of trauma or a car accident. Every single person there was there for a vision issue. It was humbling. And it really speaks to the global need for good quality eye care and why what you all are doing and choosing to do is so important. Also looking at this, cataracts. So many people have cataracts and the procedures, as you all know, are quick. They just need access. Diabetes, we all know me, I've got a little bit of waist here, right? So, the world is growing both this way and with population. But we become sedentary, our eating habits have changed. As diabetes increases, diabetic retinopathy increases as well. And I was really taken by the fact that there were more cases of retinoblastoma in rural India than I ever thought would be the case. I questioned this with Dr. Suma Ganesh, who's the head of pediatrics at Dr. Shroff's Charity Eye Hospital. And she's like, oh yeah, there's lots of this in rural India. And it really made me think about how well are we thinking about these other types of things, because we always think about cataracts and refractive error, but retinoblastoma, as I'll share with you in a moment, is, it's life-altering. And so certainly while I was there, I had the opportunity to launch a digital training hub, talk about fundamental VR with our partners, some of them who would use it, and we launched a Green Vision Center, which are those centers that are run completely on solar power. They can be put in any part of the country. They're self-sustaining within 2 to 3 years. They maintain all of their records. They use a minimum of paper, and they are cost-effective. So those of you who don't know me yet, but I don't like having my picture taken. I really don't. But I have photos here because they took lots of pictures of me, but that's only because these are the photos I have. So this is not a vanity thing. This is just what I have to share. But this is a school screening program, which we did in one of the elementary schools. And in this case here, this little boy was talking to us because he was being picked on because he had glasses. And so we were talking to him about, this book here is a picture book talking about a similar situation of a child that's been picked on. And I commented to him, I said, Dr. Bora, who's the head of our India program, our colleague here who's the head of clinical services at HV Desai, I said, we all have glasses. And look, we're okay. You'll be okay too. Glasses are very popular. And then, of course, we had a chance to see all the children, was able to go to the launch of the Green Vision Center, quite an experience for somebody who's never been to India before, a lot of flourish here, but a very well-stocked center. And this is not a center that Orbis owns. We do these with partner hospitals because what we want to do is make sure that it becomes part of the hospital network. And what we have been doing is moving more towards our school screening programs, is directing those students to the local vision center, because then it becomes an opportunity to engage the family and have the family screened as well. And so, in this case, this for me was particularly pleasing because this was a little boy who was getting his first pair of glasses. He'd been screened at school, known that he had a refractive error issue, and I was pleased to be able to speak with him about that. Here we had some glaucoma residents I had a chance to meet with, an experience with our fundamental VR technology, and of course, here just a wet lab experience as well. Surgical mentoring, and here, we had the opportunity to, these women who were all about maybe, this high on me, all wanted their photo taken. They all had come for cataract surgery. One came with her daughter. And it was all about just the gratitude of being able to see again. And they wanted to be able to express that. And this is a little baby who had just been treated for ROP. The mother asked me, she said, would you, can I take a picture of you with my child? My children are in their 20s. I haven't held an infant in a really long time. It was a little scary for a moment, but I felt very honored to be able to do that. And here, this I just want to show quickly because this speaks about partnership. So this is with us, with the director of the All India Institute of Medical Sciences. where what we had done is over a 2-year period, we had done a comprehensive analysis of what is the state of pediatric eye care in India. What equipment is out there, what's the state of the facilities that are out there, what's the need out there, so that we have now a roadmap with a number of partners to be able to go forward and treat more children. In Ethiopia, where we've been working for 25 years, our program is principally focused on trachoma. Trachoma, for those of you who don't know, is a bacterial infection which is often transmitted by poor water conditions, sanitary conditions as one means. It also can be passed along by contact. And we were there because we were, at this point, through donations from Pfizer. Pfizer donates zithromycin not just to Orbis, but to the Health Ministry of Ethiopia for a number of partners, including the Carter Center, to be able to distribute. We gave out the 100 millionth dose of azithromycin. You know, there's a target to eliminate trachoma by 2030. We are likely not going to make that. And that's because there are supply chain issues right now with azithromycin globally being available. But we're still working hard in order to make sure that we continue to educate and make sure that people understand. And, you know, I also saw quite a bit, again, of cataracts and pediatric eye care. I was at the following hospitals, again, had an opportunity to not only talk with them about some of the key issues in terms of pediatric vision being underserved, talked about the glasses piece here. We do have a really strong partnership with the Ethiopian Ophthalmology Society, which I was delighted about. I will say that I did have the opportunity to actually see a small incision cataract removal. It was me, the doctor, the patient in a hut. No windows, no doors. It was just a table. The patient had been given local around their eye, and then he cut and removed the cataract. Sewed it up, put the patch on, and the next day the person's going to be fine. But it's not what you would normally see in a hospital here in Hong Kong. It was very rough. And it was also something where it wasn't an ophthalmologist doing it. It was a cataract nurse. It was a transfer of skills in the value chain so that the ophthalmologist can do other things. But for high volume activities, finding people who can deliver that care that's so desperately needed because of so much cataract need out there, it allows for that service to be provided. So we were and you're going to see there are fewer pictures now because, you know, this is May and it's still May, but this I thought was important. You know, we were greeted by the community in the Goma zone like we were state officials. Our country director said he'd never seen this for somebody who wasn't a government leader or a prime minister, where the community came out with all of their representative clothing. They had an opportunity where we had people come together, and this little boy is the one who got the 100 millionth dose. And you could see here this stick. And what this stick does is based upon his height, it determines how much azithromycin he needs. And so that stick would go door to door, and we would put people up against it and then measure it out. In this case, he's getting the suspension. In some cases, it's the tablet. We also did a vision screening in the local school. And we also show here an example of a shared resource that we created with the Ophthalmic Society in Ethiopia. But what I will say about Ethiopia is the challenge there is all the hospitals are state-run. So in India, you had the advantage of private-run hospitals, so you have a lot more flexibility. In Ethiopia, you have state-run hospitals, so the prioritization of resources, the need for materials and supply chain becomes harder. It's not impossible, but it's harder, and because it's with the state, there's more bureaucracy involved. And then in Vietnam, where I just came from before coming here to Hong Kong, again, the need for comprehensive eye care is real. And as you know, we did with our Blind Eye Hospital program, we had more children that were treated than adults. We also had an opportunity, we've been doing DR screening and refractive error screening in Vietnam, but there are this core set of common diseases that need to be treated. Where I was complaining a moment ago about how tough things are in Ethiopia, it's a little harder in Vietnam because now you have the nature of the Vietnamese government involved as well, which is harder. But they don't have things like cataract nurses. They won't allow that. So only the ophthalmologists can do the procedure. They won't do small incision. They only do phaco. So you don't have phaco way out in the wetlands in southern Vietnam. You have to find ways to bring those people to those tertiary hospitals. So it's a problem. And so here, and I'm getting close to the end, this little girl, her name is Han. She was 5 years old. She came aboard the Flying Eye Hospital, and you can see, she had been screened. And this is her with her mom in the recovery room. And she had, as you could see, she had ptosis. She had a procedure, and now you can see where she's at. This is what it means to do what we do. This is what it means to do what you are going to do in the future, to be able to change people's lives, improve their quality of life. And I can't emphasize enough how important that is. So there are challenges as we move ahead. As you look at this, you can see the number of people with vision impairment is expected to grow. As you look at over 65, over 573 million. You can also see, as we've talked about already, some of the common diseases, diabetic retinopathy, glaucoma, as we know from the program launch yesterday, and myopia continue to be problems. Delays in treating eye conditions, limited alternative in some cases, in teaching alternatives, we're trying to address that. Under-equipped facilities and a lack of understanding by governments of the financial impacts of not treating eye care. You all know this as medical professionals, prevention first. Right? Prevention, you save a lot of resources, a lot of dollars, a lot of pain. But there are opportunities. The glass is always half full, right? So here, yes, we are increasing what we can do and adding more content to CyberSite. We need to make sure people are taking advantage of that. We are launching green vision centers to be able to target those rural communities that may not have access to being able to get to a primary care center, which oftentimes are in the metropolitan areas. We at Orbis are also working very hard to work with national stakeholders to prioritize the communication and understanding of governments, the importance of early intervention. And honestly, as a community of health practitioners, we have an ethical responsibility to do all that we can to help somebody in need. Thank you very much.
Derek, is a very inspiring and amazing overview. You walked us through some of the success stories of Orbis. Now, Orbis has become a global icon of professional eye care delivery and prevention of blindness. Now, can you share with us, as a global organization, what is the recipe for success? Success in terms of mobilizing resources, garnering supports from donors, from volunteers, motivating nurses, biomedical engineers, ophthalmologists, optometrists. What is the secrets?
Well, there is not one answer to that, I don't think. I think part of what it is from my experience at Orbis for 2.5 years now, it starts with mutual respect. I think the fact that we tremendously respect that people are willing to give their time and expertise in order to help others who would otherwise not have access to that is tremendously important. I think also the fact that people realize that without some type of intervention, nothing is going to change. And everybody in this room is here because you want to be agents of change. You want to be agents of doing something good. And that's what we try and do at Orbis. We've certainly had our stumbles along the way, but I think our ability to motivate and inspire and train people comes from the fact that we aren't about Orbis. There's no Orbis flag that goes in front of an office. There's no, expats or TCNs that go to a country and set it up. All of our solutions are locally driven. All of our solutions are about sustainability. All of it is about putting ourselves out of business someday because we're able to make sure that communities have the care that they need.
It's amazing. Now, you mentioned in your presentation that 9 of 10 patients with vision loss, they come from low to middle income countries. And I believe it's large connects with the fact that is related to basically the infrastructure, resources, policy of the local health system.
Mm-hmm.
Now, how does Orbis overcome these barriers? How does Orbis engage the government or to change something that perhaps Orbis may not have and handle on?
No, I appreciate that. I mean, first of all, we work very closely with other eye health organizations. So groups like Sightsavers, CBM, Fred Hollows, we don't look at them as competitors because we're all trying to do the same thing. I may look at them as competitors when there's an RFP out there for some work, but certainly when we're trying to make sure that we can look at change elements within health policy, those groups work with us through also the IAPB, the International Association for the Prevention of Blindness. We continue to work with that, but we don't have a lobbying group. So for us, a lot of what we're trying to drive to is our country director engagement with KOLs, and it really does come back to doing research and having data to put in front of people. It's one thing for me to be able to try and persuade you on why you should donate to Orbis or why you should believe that putting a vision care center here is important. It's another thing for me to show you a data argument in terms of this is what it means. And so we have been focusing a lot more of our attention on building our data assets. But it is not something that Orbis is able to do alone. I'm not going to lie. It is a community effort that has to take place.
I think the track record that Orbis has obviously touches people and it motivates people to join hands with Orbis to help. And one thing that you also mentioned about is KPI indicators, 99 indicators. Now, how would you measure impact? You talk about impact as well. Sometimes it's difficult to measure impact because blindness, sometimes, as you know, diabetic retinopathy, glaucoma can take years to progress, and sometimes even decades. And measuring impact is very difficult. So how does Orbis measure that?
Yeah, so we're not there yet, but here's my thoughts on this. Is it's going to be a bit of walking before we sprint. So with the movement away from just output indicators to looking at outcome indicators is the first step. Looking at how we can map some of those to some impacts. And for me, it may be this person was not able to be in the workforce before. Now they're able to be in the workforce. So I don't think about as much of the impact of the disease state, but the impact is what it means to their quality of life. I think that looking at the impact as it relates to the disease state, you're absolutely right. Some of this can take many, many years in order to do that. And even looking at some of the quality of life aspects may take a long time too. So this is not something that is going to happen overnight. And we are going to experiment with this. And as we start to roll out these impact indicators, I'm a firm believer in piloting. So we'll start to identify a small subset, we'll go for a period of time, and we'll assess. Are we getting anything meaningful out of this? But at the end of the day, I know that there are ways, because part of what we also can do to help surround that impact indicator piece is talk about case stories as well. So when we go into a community and we sit down with, there was a woman named Lucia in Zambia who had bilateral cataracts. Her daughter, or her granddaughter, was leading her around because she was blind. She came to an Orbis center. Her cataracts were removed. We have a video of this. She started singing and dancing. The instant her patches came off. That quality of life story and that story, that's also part of an impact of what we do.
To the degree, I mean, the pictures you show, I mean, it's amazing. A picture speaks 1,000 words. Right. And I think it's a good opportunity for our audience who are interested to know about the work of Orbis. Is the time that perhaps you can have the questions to Derek.
Yes, sir.
Yes, wonderful. I'm just wondering, you were talking about sustainability, and there's so many things that I'm sure many people would ask Orbis to do a lot of things. And how are you supposed to choose the sustainable and try to refuse the non-sustainable?
No, it's a good question. It's fascinating. When I was in Vietnam recently, meeting with a number of academic partners who are working with us on a program, I said, what can we do to help? And they said, well, we really want to do eye banking. And another person said, yes, we really want to do corneal eye bank. And I said, no, Orbis is not going to do that. Orbis has done eye banking in the past. We actually started eye banks in India. We started eye banks in Ethiopia. We started an eye bank in Vietnam in the very beginning. But that's not our subject matter expertise. Part of what has happened in the past is NGOs, bless their hearts, have a hard time saying no. And so my experience, having worked in the corporate sector, is I'm pretty good at saying no on things. And so I'm happy to kind of say that's not where we want to be. But the other part of your question is, with us in terms of when we think about sustainability, it is working with our local partners to understand what are their most critical needs. And so when I was in Ethiopia talking to them, they're like, we need more training. I said, what kind of training? Flying eye hospital, HBT. Okay, good. Now that we know it's HBT, what other type of training? Is it glaucoma training? Is it pediatric ophthalmology training? So it's really part of that Socratic process to understand more what they need and make sure that they understand that they have to have skin in the game too. So a lot of times, some of these institutions will say, especially the academic ones will say, we need more equipment. And I'm like, well, we don't have big budget for equipment. We usually have to go get it as gift in kind from Alcon or Zeiss or, one of the other ones or Topcon. But, even if we get you the equipment, you need to be able to service it. You need to think about the consumables to support it. You need to be thinking about, so, this is not something where this is a marriage between Orbis and you on when you get a piece of equipment. There has to be equal opportunity for you to think about what your role is to make this work going forward. So on the education side, I think we're very strong. I think we have good communication, good partnership, coordination with folks. I think when it gets to things like equipment and consumables, it's harder. Oftentimes, some of these countries have very weak supply chains, but I'm not going to solve that because that's not our business. I'm happy to look at other models that we might be able to help inform them with. I don't want to leave them high and dry. But I think one of the things that many organizations get guilty of is scope creep. And what I want to make sure is we think about what we're doing well. Right now, there's a shift in some of the eye health organizations. Sight Savers, for example, has been moving drastically over the years into the disability space. Helen Keller International does very little eye care anymore. They're mostly about vitamins and nutrition. CBM is moving away also from some of its vision work to more health system strengthening based upon what they learned through the COVID pandemic. At Orbis, we're about vision, capacity training, skills development, and that's where we're going to stay.
Any other questions from the audience? There are ophthalmologists here, medical students, and I'm sure some of them would like to take part in some of the programs developed by Orbis. And you mentioned Tim. Tim has participated in a number of programs organized by Orbis. Perhaps, Tim, would you like to share with us your experience working in Orbis? How?
Well, I would say it's fantastic. So thanks for the opportunity to share. So I've been actually doing Orbis trips for the last 14 years. So Vietnam is my second flying eye hospital, but I've done also other HPTs in Bangladesh and also in China. So I would say it's a very, very rewarding experience, especially seeing all the patients and the trainees that they really appreciate what you've been there to help. And in Vietnam, so I was just there last weekend. So we had this time I had 4 hands-on training, so it's a bit more than usual. Usually I only have 2, but they were very keen to learn, and I've managed to make them to be independent doing independent surgeons doing laser therapy. So which is very important because they had a laser machine sitting there for a whole year, but they have got no one to train them to use it. So that's actually I find them very rewarding. And actually in the various countries, you have been to Bangladesh, and that time was very good as well because Derek mentioned about longitudinal follow-up for these. I actually went to Bangladesh twice in a row. So the first year and the second year, and was able to see some of the patients I treated in the first year, and that was really, really rewarding. So so I can share for the whole day, but I think I'll just stop. But it's been a wonderful, very rewarding experience. Volunteering for Orbis, so I would encourage all of you to consider. Actually, I've asked a lot of my friends to do it. So, yeah. So Simon just came in earlier, so he was he actually applied to go to do the to be one of the associate ophthalmologists, but unfortunately there was no budget. So so hopefully there will be more donations coming. And of course, my wife Victoria, she's volunteered for being a VF in China program before. My anesthetist, he's also been to one of the FDH programs to do VF work for the Orbis. So even my son, actually, he volunteered for Orbis in one of doing some clerical work. So it's fun. Yeah. So thank you very much.
So this is the role model family. Okay.
Thank you so much, Tim. And I believe is an amazing commitment. 14 years is a long time. And I hope this lecture can motivate you, medical students, doctors, eye care professionals. And if you have time, you feel you have a passion to contribute to eye care around the world, please let Orbis know, let me know, and we're here to facilitate. So we have one last question at the back, please.
Hi, Mr. Hodkey. My name is Kelvin. I'm a final year student from the School of Public Health. And first of all, thank you so much for your sharing today. And one thing that I would really want to highlight that I really want to echo and I resonate with as a global health student from your sharing today is about when you talked about your geographic scope as an international organization. And I really agree that it's not just about going broad, but also going deep with each country. And I think that's super important when we talk about development and health. And it's also about ensuring that the most vulnerable are represented and protected. So one really brief question I have is that could you share with us some of the ways for Orbis to confidently know when enough impact has been done for these developing countries, and for them to further advance to other geographic regions? So thank you so much.
No, I love the question. And I was telling my team today that, you know, sitting in New York City where our headquarters is, and I was sitting back thinking about budgets, and I was thinking about priorities, and I'm like, we've been in Ethiopia for 25 years. What is left to do? We've been in India for 23 years. Can we move that to become us, you know, basically a hub for jump off to Indonesia and other countries? And my perspective, which was very binary, sitting in New York, not having been to the program, changed when I got there in person to see really what the need was. And it was humbling. So the short answer to your question is, I don't know yet. I think a lot about it, though, because I do want to make sure that as we continue to find ways to bring the preventative, the comprehensive eye care that's needed in a number of communities, that there is a natural transition that has to happen, right? And certainly with our head of global programs, Doris Macharia, who worked at FHI 360 as a maternal neonatal childhood specialist, as well as has a background in public health, you know, I'm really looking to Doris and her team to think about what's enough. And they just created strategies, you know, 5-year strategies for all of our country programs. For example, with Ethiopia, you know, my question is, well, we're going to eliminate trachoma. We know we are, right? It's just a matter of time. Then what? Is there still an Orbis need in Ethiopia? And looking at the strategy, the answer is yes. And what's the next thing? Pediatrics. So for me, I think it comes down to not only looking at the strength of the partner networks, because that's really how we get things done. We're not a direct implementer. We do our work through partnership. But I also challenged our team to grow our partner network, because I personally feel that if you've had a partner for 5 years or 10 years, it's kind of like a marriage. You kind of get comfortable, right? So, you may not pick up things off the floor at home when you're married and things like that, as opposed to when you're dating, when you're on your best behavior, right? So, I want to make sure that we have an opportunity to find partners who are hungry, who value the same things that we do. And we added 14 new partners in 2022 across our country programs, which was tremendous. But your question is one that I think a lot about as well. And I will say, for the near term, for this 5-year window of our strategy, we're in the countries we're in. I think as we come to in the 4th year of this strategy and start thinking about the next 5 years, I think a lot of what we're going to be looking at are some of those impact and outcome indicators, as well as where we see the trends moving in some of the public health efforts that are going on in those countries. But I really appreciate your thoughtful question.
Thank you so much.
Hi, first of all, thank you for the speech tonight. I just have a small question in response to the challenges you mentioned that Orbis face. So the delivery of eye care can be hindered by inadequate health system infrastructure. This is pointed out by you as part of the challenges that you face. But at the same time, you also mentioned that it is out of reach, out of what Orbis do. So I'd like to question, what exactly is your approach to this problem? Yes.
Yeah, so thank you for the question. I think, certainly we continue to try and drive people to a telemedicine platform in order to build some of their capacity. I think part of the challenge is telemedicine is never going to do it all, right? It still involves that mentoring element, and part of that means that you have enough adequately trained resources in a country to be able to help support that. And in some cases, that's not the case. So in Ethiopia, for example, the number of people who go into some of the subspecialties, they actually move into private practice. And so then you have a gap where you don't have people who may be retinal specialists, you don't have people who are oculoplastic specialists. And so there becomes this gap that you can't fill. So that's part of what I meant in terms of not having everything in place that you'd want to. But certainly what we hope to do is by continuing to recruit volunteer faculty, by continuing to identify some of the needs in these countries, looking for some local solutions, and identifying individuals who we can then sponsor for fellowships to be able to be trained in some of these subspecialties and brought back to their community. We did this in Zambia, for example, where there was a need for a viral retinal surgeon, and we sent this person to the UK. They were trained and they've come back, and now it's training the trainer. They're training the next generation of people. I hope that answers your question.
Thank you very much.
Thank you very much, Derek. So let's give Derek another round of thanks.